Assalamu alaikum, my dear student. Good morning, all of you. How are you? I am Dr. Muhammad Ruhul Amin, Registrar Department of Gastroenterology, going to shortly discuss a topic approach to a patient with edema and ascites. Approach to a patient with edema and ascites. This topic really edema and ascites in your final professional examination. You have to face various parts in your examination system, in your short case, in your long case, in your Viva board examination, in your data interpretation, and your SP examination, and definitely in your written examination, you are to given various type of written examination on the basis of edema and ascites. Because these patients are available in medicine ward and frequently given to your long case, short case, and as these cases are available, examiners are very interested to place it in front of you. And these two terms, edema and ascites, even been taught from the very first year, second year, third year, and fourth year. In a various subject, you are to be taught edema and ascites. So I think all of you are really aware regarding these two terms, edema and ascites. So I think this discussion will be helpful for all of you if you go through from the very beginning to the last. Edema. Edema can be defined as clinically apparent increase in the interstitial fluid volume. A weight gain of several kgs usually precedes overt manifestation of edema. When edema results from lymphatic stasis, the term lymphedema is used. Edema is defined as a palpable swelling produced by expansion of the interstitial fluid volume. When massive and generalized, the excessive fluid accumulation is called anasarca. Anasarca, that is generalized edema. Lymphedema, when lymphatic stasis are involved. So main thing is that excess fluid in the interstitial fluid volume apparently increase. There is expansion of interstitial fluid. This is edema. Causes of edema, I think you all know the causes of edema. There are lots of causes of edema. Low plasma oncotic pressure, increased capillary permeability, increased hydrostatic pressure, and lymphatic obstruction. This is really the main mechanism or cause. Low plasma oncotic pressure due to low serum albumin, due to increased loss in case of nephrotic syndrome, decreased synthesis, liver failure, and malnutrition. The main thing is that low serum albumin, because are where low albumin are synthesized or albumin are being lost, or malnutrition, that is low protein supply to the body, that is albumin. So there are low serum albumin, causing low plasma oncotic pressure, causing edema. I think all of these two terms is very much important for us: nephrotic syndrome and liver failure. Increased capillary permeability, leakage of protein into the interstitium, reducing the osmotic pressure gradient, which draws fluids into the lymphatic and blood. The causes of increased capillary permeability: local infection or inflammation, systemic severe sepsis, drug-related calcium channel blockers. These calcium channel blockers are very much important. Whenever we will prescribe this, we have to keep in our mind that it may cause edema. It mainly causes the increase, one of the important causes of edema, calcium channel blocker. So we have to keep in our mind. Increase hydrostatic pressure, high venous pressure or obstruction, congestive heart failure or cardiac failure. It is very much important for us. Intramuscular volume expansion in iatrogenic renal failure or Cohen syndrome. Lymphatic obstruction are causes of lymphatic obstruction are filariasis, lymphogranuloma, Beneram. So after finding a patient of edema, how to approach very easy. Whenever we will find a patient, we have to go through history taking, examination, investigation, and final diagnosis and management. History, site and distribution. Localized and demarcated sites of edema are usually due to trauma or infection. Edema may be confined to both lower limbs, for example, with inferior vena cava obstruction and pregnancy. So when we will find a patient where edema is confined to both lower limb, it may be due to inferior vena cava obstruction or and pregnancy. Edema only a single limb, such as the leg with unilateral deep venous thrombosis or arm following axillary lymph node clearance. So when we will find a patient with edema in single limb, unilateral, it may be a case of DVT or any other problem like axillary lymph node problem. And when we find a patient with only lower limb edema, it may be inferior vena obstruction and pregnancy. So localization is very much important for diagnosis of edema. Precipitating factors may be obvious from the history like trauma, infection, allergy, infection with filariasis, etc. Past medical history and drug history of irradiation or surgery, history of lymphoma or secondary to metastatic lymphatic infiltration from tumors, and detailed drug history of any offending drugs. As we know, the calcium channel blocker and some other drugs are responsible for causing edema. And what are the associated symptoms? Malignancy, cardiac failure, lethargy, dyspnea, orthopnea, paroxysmal and nocturnal dyspnea, cough, ankle edema, and abdominal distension from ascites. If liver disease, jaundice, pruritus, ankle edema, abdominal distension, hematemesis, and confusion and encephalopathy. Renal disease, nephrotic syndrome, severe generalized edema complaining of frothy urine. So associative symptoms are very very important for us. In case of cardiac failure, these symptoms will be present. In case of liver disease, look, these symptoms are present. And renal disease, in case of nephrotic syndrome, severe generalized edema complaint of frothy urine. And in case of malabsorption, there will be finding of weight loss, diarrhea, and steatorrhea. So associated symptoms are very much important for diagnosis in case of edema. Venous thrombosis. If unilateral leg swelling and pain are the main symptoms of the venous thrombosis, bilateral leg edema with the onset of dilated superficial collateral veins on the tongue and abdomen is suggestive of inferior venous obstruction. So now examination, inspection, distribution of edema may narrow the differential diagnosis. So we have to inspect very meticulously. Cardiovascular system, cardiac failure. If cardiac failure present, there will be tachycardia, pulses alternance, low blood pressure. JVP may be elevated, third heart sound with bilateral course, pulmonary capitations may be auscultated. Hepatomegaly due to liver congestion and ascites may also be present. So during inspection, cardiovascular system, cardiac failure, JVP, hepatomegaly, we have to look to find it because it will give you a clue to diagnose edema. Abdominal examination, generalized wasting from malabsorption or malignancy. If clubbing, pulmonary erythema, tuberculous contracture, jaundice, spider nevi, and gynecomastia are signs of liver disease. Look, dilated collateral veins on the abdomen may be due to portal hypertension or inferior venous obstruction. Organomegaly due to carcinoma may be present and predisposed to venous thrombosis. Pelvic malignancy may be cause venous outflow obstruction. So abdominal examination very much important. If generalized wasting, malabsorption or malignancy, clubbing, pulmonary edema, liver disease, dilated collateral vein on abdomen, inferior venous obstruction, organomegaly due to carcinoma. Legs. If presence of tenderness and swelling, circumference of both the thighs and calves are compared, and marked painful erythematous unilateral swelling may be indicative of a deep vein thrombosis. So whenever we examine a case of edema, we have to examine legs very meticulously. Major physical finding in edematous states: pulmonary edema, central venous pressure, ascites, and or pedal edema. If left-sided failure, there will be pulmonary edema. Right-sided failure, there will be ascites and pedal edema more predominant. Left-sided failure, pulmonary edema more predominant. On the cirrhosis, pedal edema more predominant. In a renal disease, pedal edema and pulmonary edema will be variable. Central venous pressure will be increased. Nephrotic syndrome, central venous pressure is variable, and ascites and or pedal edema predominant. Idiopathic edema, ascites and or pedal edema predominant. And in case of venous insufficiency, ascites mainly pedal edema may be asymptomatic. So we have to find these kind of points during examination of a patient of edema. General investigation, urinalysis to find proteinuria with nephrotic syndrome. Blood examination, total blood count, WBC count will be in case of infection and deep vein thrombosis, anemia in case of malabsorption and blood and urea, serum creatinine, urea and creatinine in case of renal failure. Liver function test in case of liver disease, serum albumin is very much important. Some specific investigation, 24-hour urinary total protein, if more than 3.5 gram of protein with nephrotic syndrome range, and after that we can perform renal biopsy, echocardiography if there are cardiac failure, liver biopsy, liver cirrhosis, and fecal fat estimation in case of malabsorption. Management, general treatment, bed rest, restriction of sodium, diuresis, local treatment, and treatment of specific cause. So, examiner will ask you from this scenario in different point. Whenever he will give a scenario with edema and just tell you that please formulate some, tell some differential diagnosis. So, what may be the differential diagnosis? Yes, differential diagnosis is very easy. Differential diagnosis will be on the basis of cardiac disease, liver disease, and renal disease. Cardiac disease is left heart failure, right heart failure, liver disease, cirrhosis, or chronic liver disease, renal disease, nephrotic syndrome. And after that, he will ask you clinically how you can differentiate these three differential diagnoses. You have to know this clinically how to differentiate. So, in case of cardiac failure, you may just answer that there will be signs signs of cardiac failure with pedal edema and ascites. Pedal edema is more predominant, and GPP will be increased. If this, if you find this, it will be a case of cardiac failure. On the other hand, liver disease, there will be stigmata of chronic liver disease, jaundice, and edema, that is ascites, will come in the abdomen first, then pedal edema will develop. So it may be a case of liver disease. On the other hand, renal disease, nephrotic syndrome, if facial swelling first, then ascites and pedal edema, it will be a case of renal disease or nephrotic syndrome. So clinically, these three different types have to differentiate. So this is really very important. And the causes of edema and different edema is the same thing. We have to know the cause, followed by how to differentiate it clinically, and just tell the some 2 to 3 investigation and management. I think it will be very easy for you if you go through this lecture, very beginning to the last. We'll perform urinalysis, blood to to define diagnosis of a case of edema. Some specific investigation or management. Okay, now we approach to a patient with ascites. Ascites refer to the accumulation of free fluid in the peritoneal cavity. So, examiner will ask you what are the causes of ascites. Ascites is frequently asked question in many parts of your examination system, in your short case, long case, Viva board. In any written question you have to face. So I think it is very much important for all of you. The causes of ascites: common causes: cirrhosis of liver, congestive heart failure, malignant disease, hepatic gastrointestinal disease, infection. And just edema and ascites is the same thing. Just a bit of difference between edema and ascites. So just a bit of different in explaining, or most of the things are the same. Just approach is a little bit different. So cause of ascites, as we know, cirrhosis of liver, congestive heart failure, malignant disease, infection. These are the causes of edema. The same thing. Other some causes of ascites are hyperproteinemia, just nephrotic syndrome, protein losing enteropathy, malnutrition, hepatic venous occlusion, Part-Chiari syndrome, veno-occlusive disease, pancreatitis, and lymphatic obstruction. Some rare causes of ascites: Meigs syndrome, vasculitis, hypothyroidism, and renal disease. So we have to know the causes of this ascites. When the examiner will ask you, just boldly answer this 3 or 4 causes. Approximately 5% of patients with ascites have more than one cause, such as cirrhosis plus tuberculosis, peritonitis, peritoneal carcinomatosis, heart failure, or diabetic nephropathy. Patients with more than one cause for ascites formation tend to be the most confusing to diagnosis. Each partial cause may not be severe enough to lead to fluid retention by itself. It is the combination of partial causes that lead to ascites formation. So we should keep in mind that ascites may develop more than one causes. Approach is the very same. History taking, examination, general investigation, specific investigation, final clinical diagnosis, management, treatment, follow-ups. Symptoms of ascites: abdominal discomfort, increasing abdominal guard, weight gain in ankle or sacral swelling. Onset: development of ascites is usually gradual but may be sudden in one of acute decompensation of liver cirrhosis, malignancy, portal or splenic vein thrombosis, and Budd-Chiari syndrome. Past medical history: any history of malignancy in the abdomen or pelvis, history of breast, ovarian, prostatic, testicular, and hematological malignancy, history of cirrhosis of the liver from alcoholism, previous hepatitis, Wilson's disease, primary and secondary bilateral cirrhosis, and hemochromatosis, history of tuberculosis. So, reviewing history, taking past medical history is very important. We have to find out the malignant causes or any cirrhosis of the liver or history of tuberculosis, because all of these things may cause ascites. Associated symptoms: shortness of breath can result from splinting of the diaphragm due to stance ascites, or symptom of cardiac failure when it is the underlying cause. Examination: classical findings are abdominal distension with fullness in the flanks. So, examiner will ask you in your examination point that clinically what are the important findings, what are the important examination you will perform in your case. So you have to that classical findings are abdominal distension with fullness in the flank, look, shifting dullness on percussion, and when the ascites is marked, a fluid thrill. A fluid thrill will be we will find a fluid thrill in case of marked ascites and shifting dullness. So flank fullness, shifting dullness, and fluid thrill. All of the three things have to examination. Associated feature of ascites include distortion or eversion of the umbilicus, hernia, abdominal stria, bifurcation of the recti, and scrotal edema. Pleural effusions are found in about 10% of patients, usually on the right side, hepatic hydrothorax. So these paragraph is really important. Inspection: evidence of liver disease, that is there evidence of stigmata of liver, chronic liver disease would suggest by the presence of jaundice, spider navy, loss of body hair, gynecomastia, pulmonary edema, caput medusa, and testicular atrophy. So in that point, the examiner may ask you what are the hand finding in case of chronic liver disease. Look, pulmonary edema, pulmonary edema. Just a single point, they will find pulmonary edema. Spiders are most apparent on the face, neck, and shoulder and upper chest, and are unusual below the umbilicus. GBP is elevated in the presence of cardiac failure. So during examination system, we have to perform all of the things. Most importantly, jaundice, spider navy, loss of body hair, gynecomastia, pulmonary edema, caput medusae, and testicular atrophy. Even the examiner will ask you what is caput medusa. what Cape food bed is. You have to know the definition of Cape food bed. I think you all of you will know. From the very first year, it is being taught testicular atrophy. Elevation of JPV cosmal signs may be observed with a pericardial effusion. Many patients with advanced liver disease also have jaundice, muscle wasting, and leukonychia, white nails. Parotid enlargement may be present, but is probably due to alcohol, not cirrhosis per se. In case of palpation, to look for possible abdominal or pelvic tumors, dipping may be required to feel masses in the presence of gross ascites, hepatomegaly or splenomegaly, to find out any hematological malignancy, and pedal edema in case of cirrhosis, cardiac failure, and malabsorption. An umbilical nodule that is not bowel or omentum, a sister Mary Joseph nodule, provides evidence for cancer at the cause of ascites. So during palpation, we have to uh, try to find out any sister Mary Joseph nodule. The examiner will ask you what is sister Mary Joseph nodule. You should note it. You have to say the causes of sister Mary Joseph nodule. There may be gastric colon cancer. There are lots of causes of sister Mary Joseph nodule. Even examiner will ask you during palpation, tell what the one single point that you may find. You have to say, you have to answer the sister Mary Joseph nodule. In case of percussion, flank fullness. However, approximately 1500 ml of fluid had to be present for flank fullness to be rejected. Auscultation to find out hepatic bruit suggest hepatocellular carcinoma. A huge farm tender liver with a bruit is much more common in alcoholic hepatitis. And the third, heart sound, systolic murmur, functional tricuspid ligation, mitral ligation, and capitation, pulmonary edema may be audible with cardiac failure. So we have to examination cardiac system very meticulously. Per rectal and per vaginal examination we have to perform. Like previous discussion, some general investigation. After history examination, we have to perform some investigation. Urine dipstick will be strongly positive for a patient in nephrotic syndrome. If a 24-hour urine collection for protein should be undertaken, more than 3.5 gram per 24 hour is indicative of nephrotic syndrome. So during investigation, we have to try to find out nephrotic syndrome. And total blood count, if WBC count is indicative of infective cause, blood urea and serum creatinine. Elevated urea and creatinine indicates severe renal impairment. And liver function test to find out liver disease. Checks X-ray, PV to find out cardiac failure and effusion, pleural effusion. Ultrasonography of abdomen and pelvis. Ultrasonography will confirm the presence of ascites. Ultrasonography will also detect any intra-abdominal mass that are not palpable on clinical examination. So ultrasonography is very much important for us. Grading of ascites: grade 1, mild ascites detectable only by ultrasonography. Grade 2, moderate ascites manifested by moderate symmetrical distension of the abdomen. And grade 3, larger gross ascites with marked abdominal distension. Abdominal paracentesis. Abdominal paracentesis is very important. Abdominal paracentesis with appropriate ascitic fluid analysis is the most efficient way to confirm the presence of ascites, diagnose its cause, and determine if the fluid is infected. So whenever we will find a case of ascites, we have to perform abdominal paracentesis. It will guide and to diagnose and find out the causes of ascites. Finding of abdominal paracentesis, turbid or cloud is spontaneously infected, fluorescent and milky. Various findings may be found in case of abdominal paracentesis fluid. Pink or bloody. Bloody ascites may be cirrhosis, leakage of blood from punctured collateral and malignancy. Brown, deeply jaundiced patients have brown ascitic fluid. Indication for abdominal paracentesis in a patient with ascites. Other tests perform on ascitic fluid. Ascitic fluid tests. Ascitic fluid test various ascitic fluids tests are available. Cell count and defined cell count. Serum to ascitic albumin gradient, which is very much important for all of us. Serum to ascitic albumin gradient. Serum to ascitic albumin gradient accurately identifies the presence of portal hypertension and is more useful than the protein-based exudate transudate concept. So it is very much important. We have to perform serum to ascitic albumin gradient. We have to know this. If the gradient is more than 1 gram per deciliter, indicates that the patient has portal hypertension with 97% accuracy. If the gradient is less than 1.1, indicates that the patient does not have portal hypertension. Cultures, other ascitic fluid test, protein, so many things. Classification of ascites by the serum albumin ascites gradient. High albumin gradient. What are the causes of high albumin gradient? Cirrhosis, alcoholic hepatitis, congestive heart failure. Low albumin gradient, peritoneal carcinomatosis, peritoneal tuberculosis, pancreatitis. All of the things are really important for you. Please note it and memorize it. Some specific investigation: tumor marker, lymph node biopsy, upper GI endoscopy, colonoscopy. So many investigation. Management, general management, rest, diet, correction of anemia, maintenance of nutrition, fluid electrolyte balance, treatment of any comorbidities, and specific management according to cause. Abdominal paracentesis with appropriate ascitic fluid analysis. This is very much important. So we are coming to the very last of our session. Summary and some recommendations. Ascites is frequently suspected based upon their history and physical examination. However, the accuracy of physical examination is variable. So we can't identify ascites on the basis of history and physical examination. Patient with ascites should be imaged to confirm or refute the presence of ascites, cirrhosis, or malignancy. So whenever we will find a patient of ascites clinically, we have to perform ultrasonography or other imaging modality. Abdominal paracentesis with appropriate ascitic fluid analysis is the most efficient way to confirm the presence of ascites. So in case of ascites, we have to perform abdominal paracentesis. It is very much important for us. Thank you very much. I think all of you go through the books reading on the basis of this session, and it will be very important for all of you if you keep in mind that in your various examination system, edema and ascites are being asked in your board, short case, long case, in your there are questions. So many questions are given on the basis of this clinical scenario in your written examination. Even in your hospital examination, edema clinical scenarios are being given. So I think all of you should go through reading these topics time and again along with your cases. So I think this session will be very important. And the next class, inshallah, will again meet with you. Till then, take care.